Okay, thank you. Thank you for the organizing committee for inviting me. So I'm going to talk about functional precision medicine. Basically, we know that tissue is necessary for diagnosis, but hopefully by the end of this talk, I'll convince you that tissue can also be used and very important for drug screening protocols. These are my disclosures. So I think many of us understand the concept of precision medicine. Typically, patients come in, they get standard of care, and they're not really put into different groups. And hopefully, over time, we could differentiate where people need to go and what therapy works for them, and also predict their response. Uh, Typically, precision medicine protocols are based on the presence of actionable mutations. And so, what that means is that if someone has a DNA mutation where there's an FDA approved drug, they're usually matched to that drug. And that is like the basis of many cancer trials, the largest of which was NCI Match, which did include gliomas. And if you look at this, this is interim results. You can see 739 patients were screened, but you can see down to 16 patients that ended up getting the targeted therapy. So there's a disconnect in terms of how hard it is sometimes to get someone to therapy. And the other problem, this is actually looking at NCI match outcomes. They stopped enrollment in 2023, so a lot of the post hoc analysis is now available. And so if you think of a common DNA targetable mutation, such as BRAF mutation, you can see that I highlighted that. If you look at the patients that actually had that mutation and then were given the BRAF MEK inhibition, you can see that only about less than 40% of patients responded. And if you look up and down that table at the number of response percentages, you can see that percent response is highly variable, with going down to 5% or less in some groups. So this highlights some problems such as, well, what is a clinically relevant driver mutation? Just because you have that driver mutation does not mean that that tumor is going to respond to the therapy. And then there are a lot of resistance mechanisms. Obviously, high-grade glioma is really, really smart. So when you translate this to high-grade gliomas, we don't even understand all the resistance mechanisms that are happening. And then thinking about combination therapies, I think the last neurosurgeon talked about this very well, that we really need to stop thinking about monotherapy because a lot of times that hasn't worked for us. So just looking at some of the recent trials with, for example, precision medicine paradigms for high-grade glioma. So this is just an example. We were talking about BRAF inhibition. What about how that works in patients? So this trial looked at both low-grade and high-grade gliomas. And if you look at just the high-grade gliomas by themselves, 33% had response by RANO criteria, which is, again, radiographic. And we'll touch upon maybe some other ways that we can start looking at response besides just looking at MRIs. And again, most of these responses are partial responses. They're not complete responses. So what is functional precision medicine? This is going a step beyond precision medicine, where you're just looking at DNA mutations and molecular characterization, and now you're adding functional testing. So you're actually taking the tissue, you're growing the tissue and cancer cells outside of the body, and you're doing drug screens. That is not a new concept. We have been growing cells outside of the body for many years, but what is new is our tissue engineering and cell engineering has gotten so much better. Our preclinical models are so much better now that we're probably going to be able to really use this in a more powerful way. So this is an example of a clinical trial for high-grade glioma specifically, 3D Predict. And in this trial, they just tell you, hey, send us some tissue. This is approximately how much fresh tissue, ship it to us. We're gonna generate spheroids, and then we're gonna give you a readout. And we're gonna give you that readout with under 2 weeks time frame. So this is a typical report that you get as a clinician. This can help you with directing the management. And you can use this for upfront gliomas as well as recurrent gliomas. So 3D Predict enrollment has ended. It ended in 2022. We were kind of one of the later people to join this group. However, we had one of the highest levels of enrollment, especially with our recurrent GBM group. So this is actually data from that consortium. This is just looking at upfront high-grade gliomas. High-grade gliomas, HGG is defined as IDH mutants, grade 4 astrocytomas, and then the GBMs are the IDH wild type. And so this is looking at the upfront data. This paper just got accepted last weekend in Scientific Reports, so it should be out soon. So you can see if you look at this that the we typically use the MGMT biomarker to try to predict who is going to respond to standard of care, in this case, temozolomide. But we know clinically that MGMT status is not 100%. And so up to 50% of patients are not responding to temozolomide. And so this test, looking at progression-free survival, you can see for both the IDH mutants and the IDH wild types, it seems that if you on this test are predicted to be a responder to temozolomide, you have significantly increased progression-free survival. If you look at multivariate analysis, this also is significant in a multivariate analysis as well. Again, being a 3D predict responder means that you have a longer progression-free survival. And you can also look at the MGMT status for these various patients. Looking at overall survival, this was a trend towards predicting overall survival, but it was not significant. And same with the multivariate analysis of a very promising work, because as we know clinically, there are a lot of people who are not really doing great on standard of care. Will that change standard of care? Maybe, potentially in the future. So some brief takeaways of some things that we've learned from our experience, and I'm just going to show some cases. So one thing is what happens when you have very complicated recurrent cases. So we obviously, you can see from our cohort, we had one of the highest enrollments for recurrent high-grade glioma. We are a center that believes in surgery when that person has a good functional status. But the problem with recurrent high-grade glioma is that this is very heterogeneous and you have a lot of radiation necrosis. And so differentiating where you're going to actually take the tissue from can be difficult. And so this is a case of a patient who had previous treatment. This is an IDH mutant high-grade astrocytoma and had a lot of radiation. I wasn't going to take them for open resection, but was going to do a biopsy with laser ablation. But I thought, well, maybe it would be helpful to send some sort of functional assay as well. And so here we're working with our neuroradiologists and MR spectroscopy to actually think about, well, rather than I have a lot of volume here, I can send from multiple places. Where should I send this from? And then this is another assay. This is another commercial assay that we sometimes use. This is tumor agnostic, where 3D Predict is specifically for glioma and also includes more targeted agents. This is just an example of what else is out there. So this is chemo ID. And so in this assay, what's interesting is they give you two readouts. One, if you look at the top row is that they're giving you readouts for the bulk of the tumor. So that's just when they're culturing the tumor in 3D structures and doing drug screening. The bottom panel is when they actually separate out cancer stem-like cells. And so that's a separate assay where they're giving you the readout. And so this is kind of an interesting concept. Should we be thinking about stem cells versus non-stem cells? And the other component is what about the rest of the microenvironment, immune microenvironment, et cetera. And I think over time, we're probably going to start integrating and getting more complex. So this is another example. In our own experience, we started just sending functional assays for various things. And so, for example, when we were enrolled on 3D Predict, if someone came into our center with a presumed high-grade glioma, we would send that assay. And so we kind of learned that, for example, a patient with a cerebellar presumed high-grade glioma, it actually was a medulla and it still worked. And so then we started to get a little creative. So for example, this is a patient who had a really complex recurrent meningioma. It was a grade 1 meningioma, but we do sequence all of our tumors, including meningiomas. It had a CREBBB P mutation, which is actually a more aggressive subtype and actually has a prognosis to recur. So this patient had multiple surgeries in their past, and then had radiation, and for a period of time was put on the Severum protocol, which for those of you who don't know is everolimus combined with octreotide. And they were stable for some time, but they live in rural Arkansas, and their primary care physician said, I don't know why you're on that medicine. You can stop it. And then their tumor just blew up, and then they come back symptomatic, but then they say, oh, I don't want surgery. Surgery is too scary. And this is an older, more debilitated person. So we ended up doing a biopsy with laser ablation. And that's a whole nother conversation about laser ablation for meningiomas. But in this protocol, again, we weren't really sure, is this going to work? It's a grade 1, technically a grade 1 meningioma. It does have some mutations that portend a poor prognosis, but we were able to send it out and get functional assays. This may be important in the future because we all probably have these recurrent meningioma patients that are difficult to treat. Unfortunately, this patient functionally wasn't doing the best, and so they didn't actually want to start some of the treatment that we identified, but it's just more of a proof of concept. How far can we go with trying to find therapies for various brain tumors, again, outside of glioma? So again, this paper just came out early this year. What about functional precision medicine for pediatric cancers? So I am not a pediatric neurosurgeon, but I think many of us are familiar with how terrible some of these cancers can be. And what's very interesting about pediatric cancers is typically a lot of them do not have actionable DNA mutations. So that is why there's room to start thinking about how can we apply functional precision medicine to identify targets for these cancers? And so this is a preliminary work, and you can see that I always kind of harp on is that they had a clinically actionable time frame, less than 4 weeks. When you're dealing with aggressive tumors, you need feedback quickly. So 3D Predict will give you a report in about 10 days. Chemo ID, because they are isolating stem cells, sometimes takes over a month to come back. So I do think this is really critical that you have an assay that can be implemented quickly because these patients are recurring. So just looking at this protocol, they were processing tissue. They did a manual disassociation first. Of course, if you use the APS system, you would probably have already disassociated intraoperatively. And then if you look, they're screening for over 120 agents. And what was interesting is that sometimes that agent was not necessarily a targeted therapy. It was just a FDA-approved chemotherapy, and that still benefited the patient. So some future directions. I think in the future, we're really going to be getting into intraoperative diagnosis. So this is a paper from a group out in Norway where they were showing that they were able to take fresh tissue from the initial portion of the surgical resection, sequence that, and give you the molecular subtype while you're still operating. So this is within about 2 to 3 hour time frame, and I admit that sometimes I'm still operating within that time frame. But this paper just came out late 2023. They've gotten better. So now they are giving you that information within 40 minutes. So again, they're doing a really quick methylation like protocol where they're looking at the methylome, and they're able to just give you that diagnostic information in 40 minutes. For us surgeons, I think this is a big deal because it will probably change what you do in surgery. If you knew the molecular subtype, you could, especially in say like medulloblastoma, you can decide, are you going to go for broke and potentially cause a neurologic deficit, or are you going to hold yourself back because now you know this is radiosensitive? So I definitely think a game changer, and I'm excited to see the next 10 years where we're going to go. The other thing is liquid biopsy. This is an example of looking at radiographic response, and on the patient on the right had a radiographic response correlated with a decrease in cell-free DNA in CSF. Of course, CSF is very invasive, so using the opening the blood-brain barrier to obtain these samples over time. What potential protocols might we implement? What are the timeframes? And so people are really thinking about this to augment what we already have. And we're thinking that likely in the future, you're going to have intraoperative diagnosis and you're going to have much more information about prognosis, and then using liquid biopsy in real time with your radiographs. I don't think you're going to, we are always stuck on, is this recurrence or is this radiation necrosis? I think over time, we're going to open the blood-brain barrier, assay for cell-free DNA, and figure that out definitively, rather than just looking at scans and tumor board. We rescan in 4 to 6 weeks. I mean, we do that all the time. So, and final, I think SSG is great to just meet a lot of people. The OTAB group, so the oncology tissue group that's sponsored by NICO. Again, we're unpaid advisory board. We're really thinking about going towards standardization guidelines. You see, it's a great group of people, not just neurosurgeons, neuro-oncologists, neuropathologists. And this is currently in submission, just our thoughts about getting towards standardization. Thank you so much.
Thanks so much, Annalie. Great to see this talk again. I just had what percentage of patients are you doing the functional precision medicine on?
So I for high-grade gliomas, like almost everyone. And then for other non-gliomas, just patients that I feel it's like a difficult situation and it's recurrent, I'm not really sure. I know I can't get a full resection, so maybe to help out the medical oncologist sending the assay.
And then for patients outside of a trial, how's it paid for?
Yes, so now there is a pre-authorization CPT code. Some of the companies, it depends on your state, so find out if it's available in your state. So that's one. There is a pre-authorization code. It's actually easier for Medicaid and Medicare patients to get approved, at least for us. And then for the private insurers, we've had variable success, but we sometimes can do financial aid packages, et cetera. So we've been pretty aggressive about that.
Thank you. Any other questions? Yes.
Okay, so I have a question regarding the responders in your study. Were they molecularly profiled after the treatment and compared with what changed before the treatment?
So in that trial with like the multi-institutional trial, everyone was doing their own thing in regards to sequencing, but everyone did MGMT methylation. Again, that's not standardized, so in different ways. We are currently working on our internal cohort where we have 28 upfront, 28 recurrence, and we have before and after. We have DNA and transcriptome. Some patients have single cell sequencing. That paper will come out, and then we do have some patients that we have before and after targeted therapy, looking at the gene expression profiles.